My name is Mariam Bishar.
Most bankable host Brian Aseli, in studio with Ronald Otieno, who's sharing his story, and of course Dr. Omanwa, who's here in capacity as a professional to just help us mortality rates and of course post hemorrhage and better ways of actually working through it.
That's right. And something Doc had said was that the numbers state that we lose about 355 women out of 100,000 that give birth. But of course that some of these, if not all, are preventable. And that begs the question, exactly how then prevent these deaths, Doc?
I think the first thing is about creating awareness. People need to know what PPH is all about, because when you talk about PPH, people are like, what is that? And remember, even in the Bible, when I think Jacob's wife was delivering, the second wife, she died during childbirth. And I think it was because of PPH when she was delivering Benjamin. Anyway, coming to where we are.
We can only speculate. But
can speculate. Coming to where we are. There are what we call factors or possible causes of PPH. When we see a patient who's carrying twins, for example, like in Ronald's, that is a possible PPH patient. So we have to be very careful how we deal with her. A patient who has a big baby, what you call macrosomia. The other time I had a patient in KNH who had delivered 4 times. The first baby was 6 kilos. The second one 4.7. The third one 4.5, and then 4. So the smallest baby she had delivered was 4.5.
Okay, which is already bigger than average.
Which is already a lot bigger than average. So that is a red flag as well. So big babies. If you have what is called amniotic fluid, which is a lot more than expected, that is also an indication that this lady can have PPH. If you have a patient who has fibroids, and you know fibroids are growths on the womb, and unfortunately women of African origin, whether you are in Cuba, whether you are in Kenya, whatever it is,
more susceptible.
The chances, yes, about 30 to 60% of these women will have fibroids, and these fibroids are usually bigger, and there are many of them. So when you have such a patient, then of course that is a risk factor. Age is also a risk factor. The younger the ladies, 14, 15, 16, because their bodies are not yet developed completely. And then the mature, I don't want to use older women, but mature women, especially when they're delivering for the first time, 37, 38, 40, and so on. So once we have these risk factors, it is very good to be prepared. It's better to be proactive. When these patients come, when you take the history, and again, if a patient has had PPH in the past, she will have a tendency of having it again later on. So once we know these factors, we are sort of well prepared. When they come, we take the history, put what we call cannulas, take blood, to be on standby, and then once they have delivered, we give them a medication to help the uterus to contract immediately. Does it always work? Not always. That is why we have to be prepared. That is from the patient side. From our side, now from the general public, like what we are trying to do now, we are trying to create awareness. We are having a PPH run on the 6th of October. And I want to invite all our listeners, and also you too, the presenters, to come and run with us. And this is basically to create awareness. It's a short run, about to 10 kilometers, and everybody's invited. Please register www.endpph.com and come and run with us. So we are creating that awareness. As we are creating that awareness, we want to pressurize the government as well, that people know about PPH. Our numbers are not good. Why are we allowing these women to die? And these some of these causes of PPH are actually preventable. Now, when it comes to the government, there are some things which it can do. Number one, provide human resource, because if you don't have human resource, there is no way we are going to reduce these numbers. So we need the experts in the field. There are some counties where you have only 1 or 2 consultants in a whole county.
Wow.
Yes, unfortunately. So human resource is very important. Number 2, we need medications, quality medications. Unfortunately, we have fake medications in the system, and you can give these medications to a patient expecting them to work, and they don't work. So she continues bleeding. Meanwhile, you have given the medications that is required. Number 3, we need blood. Very, very important aspect. If you don't have blood and this woman is bleeding, there is no way you're going to save her. Sometimes we need 10 units of blood. On Ambiwa, you can only get 2 units. What are you going to do? That is a challenge. As a country, we collect 276,000 units of blood, and of course, which is a lot less than what we need. We need about 500,000 units of blood per year.
Yeah.
And guess what? 70% of this blood that is collected is used by mothers who are delivering.
Wow.
So we need blood, a
Yeah.
lot of blood. We need commodities as well. There are some things we call, for example, uterine balloon tamponades and so on. We don't have them, and they are easily accessible and they are cheap. We also need ICU units. We have places where which are called ICU, but basically they are caricatures. You have a room without a bed, or you have a room with beds but without equipment, or you may have a room with beds and equipment, but you don't have the necessary personnel who should be able to take care of these patients once we have sorted the PPH.
Right.
So if any of these elements is lacking,
Yeah.
there is no way we are going to save these women.
I love that you've looked at it from all perspectives, all stakeholders involved, and we'll come back and wrap up this convo with a little bit more information on just exactly what you've talked about, and perhaps the resources that we can share with one another. And of course, with Ronald, or people who are in his position as